Good morning, and thank you all for joining us here today for our partner briefing on new approaches to address obesity. We have a terrific panel for you here today, a group of very expert folks on obesity and obesity research, and we really appreciate their participation today and your attendance too. My name is Sheila Murphy, and I'm the Vice President for Programs and Initiatives at Research America. And for those of you who may not be familiar with Research America, we're a nonprofit medical science and health research advocacy alliance, and our mission is to advocate for science, discovery, and innovation to achieve better health for all. And I don't want to take up too much time. I want to get onto the panel. So I'm just going to introduce people quickly, and I'm going to have to read titles because everybody is extremely accomplished. First, we have Dr. Laurie Donzi, who is the Program Director for Clinical Applications and Prevention Branch at in the Division of Cardiovascular Sciences at the National Heart, Lung, Blood Institute at the National Institutes of Health. Then we have Dr. Jasmine George, who is Research America's Lewis Sullivan Science Policy Fellow and an obesity researcher. And then we have Dr. Tiffany Powell-Wiley, Stadman Investigator and Chief of Social Determinants of Obesity and Cardiovascular Risk Laboratory in the Division of Intramural Research at the National Heart, Lung, Blood Institute. And she's also an adjunct investigator in the Intramural Research Program at the National Institute on Minority Health and Health Disparities at the National Institutes of Health. Dr. Albert Rees is Dean Emeritus and former University Executive Vice President and Endowed Professor and Director for the Center of Advanced Research Training and Innovation and co-director for the Center for Birth Defects Research at the University of Maryland School of Medicine. And he's also a Research America board member. And then finally, we have Dr. Laurie Witzel, who is Vice President of Policy Research and Translation and Senior Advisor, Physical Activity Alliance for the American Heart Association. And then our moderator leading today's discussion is Dr. Ken Thorpe, who is the Robert Woodruff Professor and Chair of the Department of Health Policy and Management at the Rollins School of Public Health at Emory University. And with that, I'm going to send it over to you, Ken. Thank you.
Well, thanks, Sheila, and thanks everybody for joining us this morning. For this very, very important topic. We know the critical role that rising rates of obesity have played in our healthcare system, certainly on the growth in healthcare expenditures. It accounts for about 20 to 30% of the growth in spending, depending on the time period you want to look at. It has an obvious bad impact on health and health outcomes among patients that are obese, because we know the prevalence of chronic disease is much higher among those patients. And just coming out of COVID, we know the interaction with those chronic conditions, COVID, and the severity of illness associated with a COVID hospital stay or just a COVID infection. So it's critical to really understand better how we can prevent this growth in obesity. And what are the new treatment options? What are the different approaches that are emerging here? We're seeing new medications coming on the market to treat obesity. We see behavior change programs that have been effective, and we want to get into all of those issues today. So that is just a very broad overview of the challenge we face. It's obviously a very substantial healthcare issue. But we want to talk about some of the solutions with our panelists today, what's emerging and what's on the horizon. So with that in mind, I'm going to start with Laurie Donzi. If you could tell us a little bit about what the priority areas are for NHLBI in obesity research. You had a workshop recently about obesity treatment and prevention research. Can you talk a little bit about that?
Sure. Hi, I'd be glad to do that. Before I start, I just want to say that although I'm here from NHLBI, what I'll be sharing represents my own views and not necessarily the official views of NHLBI, the NIH, the Department of Health and Human Services, or the federal government. That said, however, at NHLBI, we're very interested in understanding and addressing the social and structural determinants of obesity and cardiovascular health in general. So that is one of our main priority areas across the Institute, but specifically as it relates to obesity. We are also interested, and also other institutes across NIH are interested in understanding the heterogeneity of obesity, broadly defined as it relates to heterogeneity in risk for obesity, prevalence, metabolic sequelae, outcomes, and heterogeneity in treatment response. So those are two areas that we're really interested in. And I'm going to switch my view so I'm not looking at myself. And in terms of my workshop, NHLBI sponsored a workshop recently called Advancing Interventions for Adult Obesity to Promote Health Equity, State of the Science and Research Opportunities. And this was co-sponsored by other institutes and centers across NHLBI, as well as input from the CDC, the VA, and PCORI. And it was a 3-day virtual workshop. In October, we had over 100 participants, and we had 34 expert presenters and 4 discussants. And we did highlight state of the science, the new medications available, some technology-related interventions, and as well as some novel dietary interventions. But some of the priorities, or the priorities that came from the workshop basically were, again, the social and structural determinants of health and how those affect obesity. That there was a need for better implementation and dissemination of effective treatments to populations at highest risk. And let's see. And another kind of cross-cutting theme was community engagement and, really involving patients and key stakeholders in the research process from the very beginning throughout to, dissemination of results. So those were some of the priority areas that came up at the workshop. And we did have one presenter who discussed weight stigma and bias, and that was an area that everyone felt was really important and needed more research and attention in the future. And I also just want to say that we are working on the executive summary, and so the executive summary and recordings of this workshop should be available pretty soon on NHLBI's public website. So keep an eye out for that if you're interested. So that's it.
Well, thank you, Lori. Let's turn to Dr. Reese and have you talk about what effects you've seen of obesity and diabetes on pregnancy change since you started in your field.
Well, first of all, Dr. Thor, thank you very much for leading out for us and for coordinating this very important topic. And I want to certainly affirm Research America's efforts to make this an important topic for discussion and for potential solutions. Now, what's interesting is the fact that there's been a rapid change. I can recall when I was in training in the 80s, for example, the patients whom you saw, pregnant patients with diabetes, were primarily type 1 and gestational diabetes. In fact, type 2 was called at the time adult onset diabetes. So you saw that in your grandmother or grandparents. You didn't see that typically, you didn't see it ever in teenagers, and certainly young adolescents, you didn't see it. So if you had to get a flavor for the ratio, could have been 95% of patients at the time, 30 plus years ago, would be during pregnancy, would be your type 1 or your gestational diabetes. And maybe 5% or less, depending on where you are, would be type 2. What has happened since then is that we see a significant rise in obesity and diabetes going concomitantly. And as a consequence, interestingly enough, it's so impactful that there's a new term that's now been coined called diabesity, referring to that, the conjoined nature of obesity that has actually driven up the rate of diabetes. So in a typical high-risk pregnancy practice or clinic, to today, the ratios entirely changed. So 90% of the patients who have diabetes would be type 2 and gestational, and no longer type 1, which in the old days we called it juvenile onset at the time. So you'll see that that is quite a difference. The reason why that's important is because type 2 diabetes brings with it a number of other complications. It's not just the coexistence of another comorbidity, but rather the induction of other complications. For example, as I said to you, obesity was going to increase the risk of developing diabetes. 80% of the type 2 diabetic patients are themselves obese. It's also multi-generational, because the likelihood of an obese patient, the impact of an obese patient is having a large baby, and also the mother developing diabetes. It has been shown that the mother who developed diabetes also has an impact on the child. So it could be multi-generational. So the epidemiology is very, very clear. It's very impactful and can have significant complications. So I think this is such an important topic, because we're not just dealing with a one-off. We're dealing with a condition, obesity, that is so has so many prongs, so many tentacles. Its impact on diabetes cannot be overestimated.
Well, thank you for that. Moving on to Tiffany, on a different angle in this. You're leading an NIH intramural research project. Can you describe examples of addressing obesity through community interventions? And what kind of research outcomes have you found that would lead you to any conclusions about the impact of physical surroundings on the risk of obesity?
Sure. Thank you, Ken, for the question, but also thank you to the organizers for the opportunity to be here. And as Lori mentioned, I represent myself, and not my views aren't necessarily those of the federal government. But to talk a little bit about the work we're doing in my lab, we're focused really on how social determinants, again, those things that are related to where we live, where we work, where we play, our surroundings and the psychosocial factors that relate to those. We want to understand how those lead to the development of cardiovascular disease and risk factors like obesity. And so we do that in many different ways. We really take an interdisciplinary approach in that type of work. But one of the big areas that we focus on is engaging communities, particularly in the Washington, D.C. area, to better understand what they want to see in interventions, and then design interventions that target not just their individual health factors like physical activity, but also target and better help them utilize the environment in which they live. And so to give you an example of our intervention work, we started many years ago working in the community. We built out a community advisory board that's been basically working with us to provide input as we designed and implemented our studies. And through that work, we were able to see what health looked like within the community, but we were also able to identify physical activity as an important target for intervention. And we were able to better, to basically design a physical activity intervention that uses digital health technology to promote improved physical activity and improved cardiovascular health, particularly for African-American women in resource-limited areas of Washington, D.C. And so this intervention has been designed in an iterative process. So we've gotten feedback at each stage on the different pieces of the intervention. And now we're at the point where we're implementing an intervention that basically is trying to understand if we provide information about how women can utilize their environment for physical activity, if that information helps over and above information just on why physical activity is important. And so what we've learned, not just in the intervention that we're doing, but also in many of the epidemiologic studies that we do in looking at this connection between especially the environment, its surroundings, and obesity as a risk factor, we've really learned that that your surroundings can affect your risk for obesity and cardiovascular disease. We've shown, for instance, that if you live in an environment where it's less safe over time, you're at higher risk of weight gain over time. We've shown that if you perceive your environment to be unsafe, or if you perceive that you don't have the resources within the environment that you need, it's related to obesity and cardiovascular disease risk as well. And there are a number of studies that have supported these connections between the physical environment and the development of obesity and cardiovascular disease over time.
Well, thanks. That's really some terrific, important research that really kind of adds a different dimension to this issue for sure. Turn now to Jasmine. So as an early career researcher, what drew you to the field of obesity research? In your opinion, what are the most pressing questions in the field that you're currently facing?
Absolutely. So as you know, Lori and Albert have said before, obesity is a multifactorial condition. And that's what really drew me to the field, because I was initially interested in diabetes and how to, kind of address the problems with diabetes and address how we think about diabetes and specifically kidney disease. And so obesity is also an independent risk factor for type 2 diabetes. So for the most part, my research was very, very, very closely related to the field of obesity, especially looking at diabetes. And so I studied specifically ectopic lipid accumulation, and so how the accumulation of fats specifically from your diet can accumulate in places in your organs where it should not be and lead to further exacerbation of many problems with your kidneys, your liver, your heart. And so that's what really initially drew me to the field, just that interaction between obesity and diabetes and how obesity can feed diabetes and worsen some of the complications there. And so from that, that really kind of taught me the importance of the root cause of diabetes. What is causing, or not diabetes, but obesity? What is causing obesity, and examining that connection between genetic links of obesity and particularly how it can impact treatment down the line. And we were also looking at some of the social determinants that may lead to obesity onset. So low socioeconomic status, access to generalized healthcare, attitude towards healthcare. And then finally, another topic would be how to compassionately address obesity and its comorbidities, because the last thing we want is for people to not feel excited about their health and equipped with the knowledge to kind of address their own condition.
Well, thanks for that. Again, another interesting angle here that our panel is looking at. Certainly multiple determinants here, and that's the bad thing. The good thing is it provides multiple policy avenues, I think, for us to look at this. We also have Lori from the American Heart Association here. I was wondering if you could describe the research and advocacy priorities of the Physical Activity Alliance.
Sure. Thanks, Ken, and thanks for the opportunity to be on this esteemed panel today. It's such an honor to be with you all. I have the, it's really great to have the chance to talk with you about our work to bring the physical activity community together. It was just before COVID that we met in Washington, D.C. As advocacy organizations, researchers, and those in the physical activity space, and talked about the idea of coming together more as one, speaking with one voice on policy and systems changes. And there was agreement that we needed to do that, and it took about a year, but thus was born the Physical Activity Alliance, and it was a merger of some organizations and others who wanted to be involved. And the American Heart Association is providing some administrative backbone for the Physical Activity Alliance, but we are growing each year, and we now have 18 board level organizations. But we have the National Physical Activity Plan, which is the roadmap for implementing the physical activity guidelines for Americans. In that part of the Alliance, we are engaging with the top researchers in the field of physical activity. On the policy work that we're doing, we have over 100 organizations engaged with us on policy and systems change work for physical activity, integrating it across settings and systems. And then we have our work in professional development to support those early career professionals, public health practitioners. So we're really excited about the breadth of our work and the opportunity to connect across that continuum. One of our major initiatives is our It's Time to Move campaign, which is our effort to integrate physical activity assessment, prescription, and referral into healthcare delivery. And we are in the midst of this multi-year, multi-pronged effort, engaging with federal agencies, working in the HL7 process to develop standardized measures for assessment, prescription, referral, working with the Office of the National Coordinator to integrate physical activity assessment into the US core data standards for interoperability, talking to NCQA, CMS, other agencies, because it is a multi-stakeholder and multi-government agency effort, and probably also including Congress and legislation to get this work done. So at the end today, we'd be excited to answer any other questions the audience may have about our work.
Well, thank you for that. A very exciting agenda. Let's move back to Dr. Reese for a minute. So as a physician researcher, what approaches can health professionals and researchers take to encourage people living with obesity to seek treatment?
Ken, this, as you know, this is a very difficult topic, and if it were easy, we wouldn't have the issue to be talking about. So what we have found, at least in using the pregnancy state as a means of extrapolating, we find that women are particularly motivated around the fetus. They're motivated around the infant much more so than themselves. So if you can somehow use the unborn as their target, for example, if we would say to women, it's important that you enter into a weight reduction program for your health and for the future and for your well-being and for your family. They certainly accept that, and they certainly will say, well, we'll try, I'll try, and we will work together, my family. And that may go on for months or years, and incremental reductions occur. On the other hand, if you say, well, it's going to be important for the pregnancy, for the success of this pregnancy, and for the infant, for you to enter into a weight reduction program before conception, that actually works almost like magic. there's a certain attachment, certain willingness to be very much engaged in health improvement, health enhancement, weight reduction on behalf of the unborn. So we find that to be a real, at least in pregnancy. And the examples that we give all the time, for example, is that in diabetes care, you'll find that outside of pregnancies, women will have their glucose values in the up and down range. In pregnancy, they're very vigilant, and you can have the glucose levels almost normalized. And even before we had continuous glucose monitoring and you had intermittent sampling, they were willing to sample their fingers 4, 5, 6 times per day during pregnancy, and less so when not pregnant. So again, my point is that paradigm, which has been so successful in pregnancy, could be extrapolated to the non-pregnant world, to the extent that there could be a advice or identifying something that is important, an event, a circumstance. That it's not enough just simply to say it is important for your health, but rather it is important because you have a family history. It's important since you already have some evidence of injury. It is important that you see this and there has to be that connection. I'm not a social scientist researcher, but I think the experience that I've had in both translation research and basic research lead me to realize that using an important catalyst that is embraced as very important becomes a very, very strong motivator for women and individuals to enter into a weight reduction program. The other point I want to make, and that is, we have made good progress, and I'm using the big we, and that there are a number of options available. And so we should present those options. It's not just saying go and exercise X number of times. There are many options available. And so individuals or patients should be given the option. We know what the primary drivers are, but there are options that run from diet to medication to surgery, depending on the circumstance, and they all should be given because a single one may not be effective for this particular person or that, just based on socioeconomics, based on individual preferences or habits. So those need to be given as elements to work with.
Well, thank you for that. So Jasmine, you're an early career researcher. How can we encourage more researchers like you at the early stage to get involved in this research?
I would say the most obvious answer would be funding. Having funding for research, having funding for determining those social determinants of health and the root causes of obesity, or even just, funding the research to classify other aspects of obesity that we might be not privy to, would be the easiest way to get early career researchers incentivized into looking into obesity. Another would be mentorship. If you see a young budding scientist who is interested in the field of obesity, kind of take them under your wing and really nurture that passion and nurture that research interest as a way to really fortify this field of research, because it is an extremely important topic, and we're seeing time and time again that it is important, and it's something that we all need to address together.
Thank you for that. So terrific advice. I'm going to throw this out to both Tiffany and Dr. Reese, and perhaps you could speak to the underlying socioeconomic factors, including abuse, that contribute to the growing incidence of obesity.
So from the work that we've done in my laboratory and other epidemiologic studies that have happened, we've shown that particularly neighborhood level socioeconomic disadvantage is associated with a higher risk of developing obesity over time. There's also data to show that there's quite a bit of data to support that individual level socioeconomic status. So that means that education, income are related to the development of obesity over time. So we can think of it as really it's about having resources available for a healthy lifestyle and limited access, whether it be at the end of because of individual level circumstances, like not having the income to afford resources, healthy resources like food, or but also being in a community that has limited resources around food. Healthy food can ultimately lead to the development of obesity. And I think it's also important to remember that stress in any form, but whether it be related to adverse childhood experiences related to abuse, sexual abuse, or other types of abuse, whether it be related to, again, being in an environment that is unsafe, that is has your exposed to specifically high levels of crime. All of those can lead to the development of obesity over time. And it's not just related to the pathways with unhealthy behaviors, whether it be diet or physical activity or sleep. It's also the actual effects, the biological effects of stress that can promote obesity. And so when in the setting of a environment where one doesn't feel safe, that's going to lead to people having a greater stress response. It's going to lead to a greater release of catecholamines, or hormones, and what we call glucocorticoids. All of these biomarkers are released and actually can promote the development of obesity over time. And those are pathways that we know something about, but there's quite a bit more to learn over time. And I think within that idea of the effects of stress and the outcomes related to stress and its connection with obesity, we also need to think about the ongoing stress of being stigmatized as living with obesity and having obesity over time. And I know one of the comments was we need to even change the language that we use in how we address obesity. We need to, use person first language where we talk about people with obesity as opposed to describing it in different ways, and really highlighting just the complexity of obesity as a disease.
Thank you, Dr. Reese. Do you want to add something, or?
Well, just very, very briefly, I think Tiffany covered it very well. So I just want to say very, very briefly that is the environment can have a tremendous effect on almost anything. And I just want to emphasize that the environment doesn't have to be the physical environment. There's also the in utero environment, what the infant is exposed to, that's an environment. But there's work done actually in the state of Maryland several years ago, where we looked at the presentations of comorbidities, not just obesity, but obesity and chronic diseases, and found very, very clearly that in certain zip code areas, as precise as that, when there are deficiencies in health services or health or human services, there was an increase in the morbidities, obesity, diabetes, hypertension, the use of emergency rooms. They're just, and you might wonder why. Well, we know that obesity, the primary drivers are basically the quality and the quantity of eating, coupled with sedentary lifestyle. As Tiffany pointed out clearly, if you're within an environment where there's a safety issue, certainly not going to be walking around the block several times late in the morning or the night. So clearly the environment makes a huge difference on the onset of obesity. Ken, if I may make one other comment, if I may.
Sure.
And relate to the question that you asked me earlier, I want to emphasize this. There are newer data now showing that obesity can also lead to be associated with birth defects of infants. And I bring that up because, again, when one realizes the severity of the potential severity of an illness, of a condition, one is very motivated to do what one can to either improve the condition or to prevent the condition. And so it is very, very clear. I have a research lab and we use experimental animals to conduct our research. And we've been able to do this at will. So it's not a theory, it's something in practice. Likewise, we can prevent them from occurring, and we can even reverse the condition depending on how serious it is. So that becomes an important fact that folks should understand, that obesity is not simply the excess weight that is innocuous, but rather it's excess weight that can actually induce a condition such as diabetes, and it then result in serious birth defects. I don't mean a little pimple or a little bump. I mean a heart disease, brain disease that can lead to either death or morbidity or disability. So these are just so very important points that I believe can serve as a method of education, but also a method of information to which someone can try to apply in their own lives. Thanks.
Well, thank you for that. Well, we've had a lot of discussion about the underlying causes of obesity. I want to just take a couple of minutes perhaps to talk about some of the solutions and access to appropriate treatments to prevent and manage obesity. So maybe Lori W., if you could comment on that.
Sure. I'm also seeing the comments in the screen. I just want to quickly address this idea of language the clinicians use is so critically important. We pulled together a roundtable, which Tiffany was part of several months ago, to really help us at the American Heart Association think our way forward. And we purposefully invited those with lived experience. And I'm reading some of the comments here from the question and answers. And how we talk about this is so critically important. We heard loud and clear in that session that obesity is a toxic term for patients in a weight loss journey, and that we really need to reframe this in a culturally appropriate, empathetic means of conversation, helping people in their journey toward healthy living and well-being, promoting health. And it is a multi-pronged effort, just like our work with the Physical Activity Alliance. There's just so much synergy, and Bill Dietz and I have talked about opportunities to work together, because we should all be coordinating in our work to address, whether it's performance and quality measures, to incentivize clinicians to ask and assess and treat in the most appropriate, culturally appropriate way. That we have coverage determinations for comprehensive weight loss treatment. That would include drugs and surgery and of course, support for healthy living. And then, the idea of incorporating digital health and health technology, telehealth, and opportunities to support patients in their journey with technology. And I think that's a growing area, burgeoning area that needs further evidence base. But it's a comprehensive effort across different policy and systems changes. Ultimately, though, patients need to be able to find that culturally appropriate care, find the right provider who can help them at the right time in the best way.
Okay, well, thank you for that. So let's move to Jasmine, just really quickly, because I want to leave time here. We're getting a lot of great questions from from our participants, and I want to make sure that we get to those. But Jasmine, Tiffany, you mentioned some of your research also connecting immunity in obesity. Can you tell us a little bit more?
I can start off here. So again, to reiterate, my research dealt with high-fat diet. And so what we found was after around 12 weeks high-fat diet, specifically high in saturated fats, we see that the liver tissue and liver dysfunction in the liver tissue is aggravated by the recruitment of inflammatory cells to the liver, which kind of aggravates that stress response that Tiffany was talking, kind of spoke a little bit about, but on a more molecular level. And so it's been shown in many different publications that obesity in and of itself, or fat cells or adipose tissue, can serve as a secretory immune response. And we see something very similar in our ectopic model using that high fat diet. And so we see that it can come from the condition of weight gain as in and of itself, and also the intake of excess fats that might be toxic to the cells of the organs.
Okay, well, thanks for that clarification. Again, that's really important work, and it really adds to not only a body of knowledge on this topic, but again, it gives us sort of a broader framework of how we can intervene, both policy-wise and behavior-wise, to try to slow the progression of obesity and these associated chronic healthcare conditions. We have a whole bunch of questions in the chat room. I think at this point, what I'd like to do is turn it back over to the Research America staff to call through these questions. There's a lot of really good ones. So I want to leave the final 15 minutes or so for a discussion of those questions. So with that, I'm going to transition out and have the Research America staff go ahead and walk through these really, really important questions. So Samantha?
Thank you so much, Ken, and thank you to all of our panelists today. This conversation has been so wonderful already and very informative and important. So I'm going to start with a question that we received from our registrants. In what ways has technology, digital health behavior change interventions been best designed and or most effective in addressing obesity and related health behaviors among racial and ethnic minority populations? And I'll open that up to the group.
So I can start with answering some of that. So there has been a lot of work in developing mobile health or digital health technology tools for particularly in weight loss interventions. And much of that work has there has been work that has shown some efficacy in promoting weight loss and behavior change, but it has been mixed in many ways. So there, for instance, have been studies that have looked at, particularly in young adults, how technology can be used to promote weight loss and behavior change. And there have been some that have actually been effective, but some that didn't show any effects on weight loss over time. But where we really need more work is really in identifying the types of interventions that use digital health technology for diverse populations, and particularly around weight loss. We know that in many ways, those who use technology around health, a lot of the initial users have been individuals who are very interested in using technology, may be very gifted in using technology, but aren't necessarily the highest risk populations for they might not be the populations who have the highest rates of obesity, but also they might not be at the highest risk for the development of cardiovascular disease and other chronic diseases. And so there's been a lot of work in my group, but in groups like I'm thinking of Dr. Robert Newton at Pennington, who've been working to develop the and create interventions that target weight loss and obesity using digital health technology in more diverse populations and African Americans and in Latinx populations and others who might not traditionally been those who have been reached by the digital health interventions.
I could answer that just from the policy perspective. We're working, I think there's going to be a lot of effort this year to extend the telehealth provisions from the COVID emergency, public health emergency. So that's great, that we need to, extend that capacity to use and integrate telehealth into delivery of care. But I think that also, the use of digital health devices, integration into patient care is a really critical piece. And that's going to get us into the data privacy issue too, and data sharing. Who owns, patients should own their data and they should know who their data are going to. And I think at different places along the healthcare spectrum, people are going to need different things. Like doctors don't want this huge data dump off of your devices. They need a kind of a high level summary. But the person who might be providing the service, whether it's an exercise prescription, dietary counseling, et cetera, might need more information. And the patient should be able to determine who gets what. And we're going to have to wrestle with privacy. It was really disturbing yesterday to see that telehealth companies have been selling patient data during the COVID, public health emergency. So that's an important topic. And then I do think, as Tiffany said, we have to continue to build the evidence base for what works, what makes a difference in shifting, and helping people live in a healthier way and support them in their weight loss journey. So lots of work in this space. It's going to be an exciting area in policy development.
Absolutely. Thank you both so much. And while we're with you, Lori, we have another question for you. How can we ensure people living with obesity have access to the appropriate treatments that they need?
Oh, it's a great question. And so that gets into some of what we were talking about before, whether it's access to health insurance that is quality health insurance, and then that they're able to connect with and find a provider that meets them where they are and helps them in their patient care journey. But we have to get, work on coverage and reimbursement issues. We've got to, and then there's the family and social support that surrounds patients. And we had some notes in the question and answer. It is really important that we surround people with environments that support them in their journey. And so the other policy work that we're doing on the access to healthy, affordable food and nutrition security, and assuring that our communities are built in a way that allows us to avoid crime and walk our streets, access public transportation, and then all the work we're doing in getting access to care policy. And so it is a huge endeavor, and that's why I think bringing people together in this work. I appreciate today some of the conversation as we bring multiple stakeholders around the table to address this. We don't do it alone as organizations; we do it together, and that's where I think we're going to be most effective in supporting people in their journeys.
Excellent. Thank you so much. Another question for Lori Donzi. Can you speak to some of the new medications and treatments that may be available for treating obesity?
Sure, that's to me.
Yes.
Okay. Yeah, well, there are new medications being studied and developed currently that are showing really large weight losses. The GLP-1 receptor agonists that were originally used to treat diabetes are now being used for people with obesity who don't necessarily have obesity. So that is one type of medication that's being studied. And NHLBI is currently funding a study looking at the long-term effectiveness of phentermine, which is a generic medication that is relatively inexpensive and on the market, but has only been approved for short-term use. So there's some thought that medications for obesity may need to be taken long-term, like medications for other conditions. Bariatric surgery is another treatment that is highly effective, that does not, that is not really accessible to very many people. Really only 1% of patients who may be eligible for those procedures are offered it. So those are some of the new things. Another approach that you may have heard of that was discussed in my workshop in October was the medically tailored meals, which is kind of a dietary and economic intervention where it actually provides meals that are healthy and portion controlled to patients with obesity or other medical conditions. And that can be very effective, both in terms of, giving them access to the healthy foods that they need, and also just it being kind of portion controlled if that's what they eat. So that's something that's really exciting and new, and that different insurance companies, including, I think, Medicare is doing a large study of that approach right now. And hopefully it will, if the results are good, it will become a more standard benefit that's offered to people with obesity or other conditions who need it. So those are just a few things.
If I could build on that, Samantha, it's a great point, Laurie. Thank you for mentioning that medically tailored meals. We're excited at the American Heart Association to be working with the Rockefeller Foundation on a $250 million research initiative that will translate food as medicine into policy and systems change. The work is just beginning. We're in the planning stage right now, but really excited to continue talking about that work and what it may lead to in terms of supporting patients.
Yeah, that's great to hear that.
Yes, absolutely. Thank you both so much.
And
So,
I was just going to piggyback on that a little bit. So I think, that idea of medically tailored meals and food as medicine, it really could have a huge impact in community engaged approaches to addressing obesity. I can think of multiple stakeholders that we work with in Washington, D.C., such as an organization called Food and Friends that actually provides medically tailored meals for underserved individuals. And so if those are the types of things that can get funding, those would be interventions that would be ready to be built into community approaches, community-based approaches to addressing obesity.
And Samantha, if I could piggyback as well. And I think this is so important because the rate of rise, if one just sort of looks on a graph, and the rate of rise of both obesity and diabetes is so steep that it's going to require multiple attempts, multiple efforts in order to curb that, slow that growth of rate of rise. And just to put into context, by 2045, which in many countries around the world, there's really no country that I'm aware of that is not going to be impacted. The rate of diabetes is going to be doubling, and that is very much fueled, if you will, by obesity. So clearly, addressing obesity in the various ways that Laurie and others commented has to be the way to go, because if not, we'll continue to have a vicious cycle. So I'm actually delighted both Lori's, relative to the efforts that are underway in having the Rockefeller American Heart kind of get together and work on that project plus NHLBI. Really, really important. Thank you.
Thank you all. I think this exemplifies exactly the approach that we're trying to get at this panel. So thank you all for your thoughts on that. So we're coming up on time and we have a lot of engagement in the chat. So I think we have time for maybe 2 more questions. We have from the chat, BMI continues to be the defining measure of obesity. Why is this given the issues around the BMI metric, especially given the uninclusive underlying assumptions it is making? Are there any new metrics in the works that are better calculations of one's obesity/health status?
So I'm happy to discuss that. So we know that there are limitations to body mass index as a marker for obesity, or as a measure related to obesity. For instance, for diverse populations, particularly, for instance, in Asian populations, the BMIs that we use for what we consider as cut points for obesity are actually too high, and we need to really think about more ethnically and racially and ethnically appropriate cut points for many of the measures that, like BMI, but other measures that we use for adiposity. And so one measure that we know is more related in some ways to particularly the development of cardiovascular disease is waist circumference. And again, that is something that needs to reflect the best cut point for different racial and ethnic groups. But there is data to suggest that waist circumference, and because it measures really the central adiposity, it seems to be more of an indicator of cardiovascular risk and the development of cardiovascular disease over time. Waist circumference is a better indicator of visceral adiposity, or really central adiposity, or adipose tissue around the organs. And that we know leads to release of inflammatory markers, which actually promotes the development of atherosclerosis, and the development of not only coronary artery disease, but also heart failure, and changes actually within heart muscle that promotes arrhythmias, the development of arrhythmias over time. And so even in our recent statement that we put forward, looking at the connections between obesity and cardiovascular disease with the American Heart Association, we highlighted that waist circumference really needs to be considered as a measure that's used more clinically. But we've also talked about in prior statements the need to really think about more the limitations of these measures across diverse populations.
But I may also add one other thing, Samantha, and that is, I totally agree with Tiffany relative to the fact that it's not a perfect measurement at all by far, and certainly waist circumference is very important. The problem that we have is that it is really intended to really reflect the impact on health and disease. So it's imprecise, and trying to make modifications without very good data, health data, because if you use as your outcome variable the disease or the health complication, then there's no study that I'm aware of that actually has done that just yet. So even though we realize that BMI is not ideal, it's not perfect by any means, modifying it in any way relating to racial, ethnic, geographic, may sound very attractive, but at the same time, we don't have the scientific data to show that modification would actually result in better health outcomes. So that is really the ultimate ultimate endpoint is health outcomes, and not simply to have a modified BMI. So admittedly, it's not ideal, it's not perfect. I agree with Tiffany that weight circumference is a very positive source. That in of itself is not perfect either. But we do need to have some more data being done on trying to measure health outcomes relative to these biophysical markers.
Excellent. Well, it looks like we're just about at time, and I want to thank you all so much for being with us today. Please do not log off, though. I'm going to turn it back over to Sheila, who will introduce our special guest. Thank you all so much.
Thank you, Sam. And thank you so much to all our panelists and our moderator, Ken. This has been just a great discussion, and I think has really helped focus on some of the solutions to the problem, which we all understand is a huge problem. And thank you all very much. I now would like to turn this over to Disha Bannock, who is the Senior Legislative Assistant to Congressman Hakeem Jeffries, who represents the 8th District of New York. He's currently the chairman of the House Democratic Caucus, and in the next Congress will be the Democratic leader in the House. And he has been leading and supporting efforts in Congress to address obesity. And we are really, really happy that Disha can be here today and talk about the congressman's work and legislative prospects on the Hill. Thank you, Disha.
Hi, everyone. It's such a pleasure to be with you all. And I've heard such great things from the conversation that was just had before me. And the experts on this panel have so much to contribute. So again, this has just been a wonderful discussion, and appreciate everyone's participation today. I'll just, start off by saying that, we most of us know here that obesity is now an epidemic in the United States and beyond. And there's so much to be done to better prevent and treat obesity moving forward in the United States. And, there's going to have to be, really big systemic changes that don't just improve people's lives in terms of obesity, but just all around health and wellness and chronic diseases, and the improvements that we make regarding our health infrastructure, food, physical activity. Those don't just benefit people who may be afflicted with obesity, but people who are facing a variety of diseases. And then, of course, there are things that we need to do that are specific to obesity, particularly around treatment, expanding access to weight loss medications, expanding access to bariatric surgery, medically tailored meals, and allowing maybe Medicare to cover FDA approved medications and intensive behavioral counseling. So I think there's like an approach that will address chronic diseases across the board, and then there are things we need to do specifically for obesity. One such example is the Congressman's Jeffries Halt Obesity in America Act. We have a small bill that would expand the CDC's high obesity program to more neighborhoods. This is a program to prevent obesity by expanding grants to land grant universities, to do activities that increase places for safe physical activity, or to have more healthy food options. And currently, a lot of the locations that the current grants operate in are a little bit more in rural areas, or what are considered rural states. But we're seeing that now, it's not necessarily just, states like West Virginia that have high obesity. There are counties that might be in states you might not think of, like New York, that have high obesity rates. And so it's not just an issue in in certain Midwestern states or in certain Southern states. It's really across most states in America at this point. There are other bills in Congress that are being, pushed by different advocates. There's the Treat and Reduce Obesity Act that some of you may be familiar with, that expands Medicare to cover FDA-approved anti-obesity medications, as well as intensive behavioral therapy, and it has a lot of co-sponsors, and is has a lot of support. So I think we will look into that. But just in terms of the bigger picture, I think there are so many factors that are contributing to obesity. But if we start at the beginning stages, looking at our food system, our agricultural system, like all the way at the beginning stages, is really important, because what's happening with our agricultural production, what's happening at the grocery store in terms of what beverages or snacks are on the shelf or are at the corner store in communities where there might not be a grocery store nearby that has fresh fruits and vegetables. Our food system in the U.S. needs to be wholly restructured to be to promote health. And there in advertising, there's advertising, online advertising, TV advertisements, that all play a factor into creating desire for unhealthy foods and promoting the convenience of fast foods and unhealthy foods. And we need to do more to attract grocery stores to underserved neighborhoods and cities and communities. So that's the food angle, and then we need to make sure that there are safe places to exercise, easily joinable, like sports or dance or exercise, groups and activities and associations for people to partake in, so that exercise is not a chore but rather an enjoyment. I think increasing access to the outdoors, increasing access to nature, hiking, outdoor recreation, kayaking, whatever it is, so that it's not just traditionally wealthier or white communities that do that, because access to nature and doing athletic activities in nature promotes well-being, happiness, health, and is a good form of exercise as well. So that's kind of on the prevention side that I spoke a lot about. And then of course there are numerous changes that people have been advocating for regarding Medicare, Medicaid, the health insurance piece, about what is covered in terms of medications and treatment that will need to be looked at and addressed. So I think I've talked long enough. I could take some questions if people have some.
Disha, I think we are close to the end of our time, and you've been very generous with your time. And there have been some questions that we haven't gotten to. So what I'd like to suggest is, if people still have questions they'd like to have answered, which we're thrilled about, and is, I think, just a sign of how important this topic is and how much interest there is in it, please email Sarah Chang, who is going to put her email in the chat, and we will work with our panelists to get answers to your questions. And I really want to thank everybody, all of our panelists and our moderator, and then all of the participants. And this has just been a terrific discussion, and I hope it has really helped advance approaches to addressing obesity and helping people, lead healthier lives. So this has been terrific, and thank you all so much. And everybody have a nice holiday. Bye-bye.